Welcome to Milestones, your daily snapshot of maternal nutrition breakthroughs. Today, Professor Sant Rain Pasricha is joined by Professor Andrew Prentice to talk about combating maternal anemia.
Welcome to another of our podcasts on Milestones in Maternal Nutrition, part of the wider series of NNA Bites Big Learnings. I'm your host, Andrew Prentice. Today, we're talking about combating maternal anemia, and it's my huge pleasure to be joined from Melbourne by my friend, Professor Sant Rain Pasricha from the Walter and Eliza Hall Institute of Medical Research, WEHI. Welcome to our podcast, Sant Rain.
Great to be with you, Andrew.
Santa, as we usually call him, has been a great collaborator and supporter of my own team here in the Gambia. And in our joint studies, we've looked at how hepcidin mediates iron status and so forth in low-income populations. It would be great to talk about that, but that maybe will be another podcast. We also bond over the great game of cricket, a comment that will be best appreciated by our, I hope, many listeners in the Indian subcontinent, in West Indies, South Africa, New Zealand, or in Santa's home country of Australia, who sadly thrashed England in the last Ashes series. So moving rapidly on from that. Sant Rain is a true polymath with a remarkable range of skills and expertise, ranging from the real intricacies of cell biology, through his core specialism as a hematologist, to epidemiology and, as you will hear, global public health policy. He obtained his Bachelor's of Medicine and Surgery with honours, followed by a Master's in Public Health and a PhD, all in his native Melbourne, where he returned a few years ago after a postdoc fellowship with Hal Drake-Smith in Oxford, where I first got to know him. He's a Fellow of the Royal Colleges of both Physicians and Pathologists of Australia. Sant Rain is now head of the Melbourne School of Population and Global Health at the University of Melbourne, and he also leads the Anemia Research Lab and the WHO Collaborating Centre for Anemia Detection and Control at WEHI, where he drives research from the molecular level to global public health and has many trials ongoing, especially in Bangladesh and Malawi. Among many awards, he's been honoured with the Australian Academy of Health and Medical Sciences Jean Jaurès Medal and very recently the Gustav Nossel Medal from the Australian Academy of Sciences. An incredible CV. Congratulations, Santa. I don't know how you do it.
Thank you, Andrew. That's very kind. And commiserations about the cricket next time.
We hope so. Now, maternal anemia is a broad and complex topic, so we must necessarily stick to some of the major headlines here. And maybe, as I said earlier, get you back for a deeper dive for some of the topics in future podcasts. Tell us, Santa, first of all, how we define anemia in women and the role that you in particular have played recently in re-examining the cutoffs we use.
Thanks, Andrew. Indeed, anemia implies a reduction in hemoglobin concentration. Hemoglobin is the molecule that transports oxygen around our body. And so if our hemoglobin concentration is low, we can't transport oxygen. And so we feel fatigued, lethargic, and tired. And so, but we need to find a threshold, a number in that hemoglobin concentration below which we define anemia. Ideally, that's done as the fifth centile, or the percentage, the line in the distribution below which 5% of the healthy population would lie. And we looked to see how this was done in the first place, and we found that initial studies were done back in the 1950s and 1960s, and WHO had essentially used those similar numbers all the way through to the modern day. So to check in on those numbers, we took a large number of data sets from all over the world, from North America, Europe, from Southeast Asia, South Asia, and even Latin America and Australia. And we were able to look for and generate healthy populations from those data sets, and then look at where that fifth centile lay in those populations. And what we saw was that in women, that threshold was 120 grams per litre. And in pregnancy, it was a little bit lower at 110 grams per litre and a bit lower in the second trimester as well. And so this gives us confidence that those thresholds are relevant to the modern world and using modern ways of measuring anemia. And using that information, the World Health Organization recently updated the recommendations to reflect the sources of knowledge around their recommendations for thresholds.
So, Santa, I know that the thresholds in children change, but we're talking about just women here. So tell us what was the only change, in fact, in terms of the recommendations for women. And before you say that, I'll just convert for people who use the different metrics, which is 110 grams per litre is, of course, 11 grams per decilitre. So what was the change that WHO made?
There were two really big changes. The first was that in the second trimester of pregnancy, that threshold came down to 105 grams per litre or 10.5 grams per decilitre. And then in young kids, we also saw a reduction in the very youngest kids under 2 years of age.
And we're going to be talking in a while why that threshold goes down in the middle of pregnancy, a really important topic. So, given those numbers, can you now give us some numbers on the global prevalence of anemia and talk about the WHO targets for anemia reduction, which I know you've been incredibly involved in, including recently publishing the Lancet Commission on Anemia, getting back on track to meeting global anemia reduction targets.
Indeed, Andrew. So there's a lot of anemia in the world. Indeed, about 30% of women around the world are anemic, and about 35% of pregnant women are anemic. And these numbers are much higher in low income countries, particularly in sub-Saharan Africa and in South Asia. For example, in pregnancy, that number approaches 43 to 44%. There are certainly pockets of the world where that prevalence will increase to above 50%. So it is a tremendously high amount of anemia. It's worth thinking that sometimes we use the word burden of anemia rather than prevalence of anemia. So I've described how much anemia there is. Burden's a slightly different term that reflects how the global burden of disease classifies anemia, and that's related to not just the amount of anemia in the world, but also incorporates how severe that anemia is, how low those hemoglobin thresholds are.
Mm-hmm.
The World Health Organization set a target to see a reduction in anemia prevalence by 50% by last year, by 2025. And what was very disappointing is that no country in the world is actually or was on target to meet that objective. And the Sustainable Development Goals have also incorporated the identical target of a 50% reduction in anemia prevalence in women by 2030 as one of their indicators. And again, of course, there is no country that is on target to meet that. And so we were commissioned by the Lancet Haematology to try to really think about why the world is off track to meet these targets. And we certainly evaluated some of the science, some of the other unmet needs about biology and interventions. But we also thought, let's take a modeling exercise and rationally understand what could have been achieved if we had been delivering all of the known anemia solutions at scale globally. What actual number could we have actually achieved as a global community? And it turned out that if we had dialed everything to 10, if we had delivered, incorporating what was already been given at baseline, and these include both iron interventions and solutions to address infection, we would have probably only been able to reduce anemia prevalence by 20%. And so actually the analysis suggested that those targets were very ambitious and potentially a stretch goal beyond what could have been achieved simply by delivering the interventions we all have in hand as recommended by the World Health Organization.
So, Santa, that's a big challenge to WHO. Essentially, in shorthand, you're saying you got it wrong. This overambitious target was never going to be met, and you have said that in several of your writings. How have they responded to that?
Well, I really respect the WHO, and I think it's important to think about the role of these targets, what they're seeking to achieve. Just like you, Andrew, I'm a scientist. I believe in data and in really being able to measure and have objective outcomes related to the things that I'm trying to achieve. But it's worth thinking about public health from many different dimensions. And one of those is advocacy and convening and sourcing funding to catalyze action. And I think there the targets have quite a different role. But I think what's important is that we understand what can be delivered versus what is aspirational or what we require further knowledge to unlock. And perhaps a way of expressing these targets might have been, for example, that if we deliver optimally for the world's population, we can achieve a 15, 20, 25% reduction in anemia over the time course. And failure to do that would definitely imply a failure to implement the interventions we have at hand. But beyond that, we certainly need those upstream improvements to public health around water sanitation, infection exposure, better nutrition across the board, exposure to indoor air pollution and outdoor air pollution, and all the other multifactorial components that ultimately do impact the lives of people. And we know that anemia is often the end state of a broad range of different effects. So I would like to have seen a target perhaps broken up into those two components, maybe the deliverable or achievable goal through the interventions, and then the stretch goal about improving public health more broadly. And I think that would have been a reasonable way to express these targets.
And what I love is that you've proposed different ways of doing this, and you've proposed that this should be sensibly based on health metrics. So you should try and concentrate efforts in places where they will have where there's the greatest need, of course, and also where they'll have the greatest impact. So much to still be talked about there. So let's now focus on how anemia affects women in particular and across the reproductive life cycle, starting with a few words in adolescence before we'll then go on to talk about pregnancy.
Indeed, anemia is a problem across the life cycle. Ultimately, firstly, we should certainly say anemia is that reduction in hemoglobin, but it has many different causes. And one of the most important ones is, of course, iron deficiency. Iron deficiency occurs when there's not enough iron in storage iron in the liver to provide iron to the bone marrow to enable production of hemoglobin. And so we see that reduction. And just to say, iron deficiency, we commonly think of it as a nutritional problem, as a condition where women or children don't get enough iron in their diet. And so therefore they run out of iron stores and they become anemic. But actually, I would challenge that we should also think of it as an iron loss problem. And iron loss occurs with blood loss. So I used to work with the Australian Blood Service, and we found that a lot of Australian blood donors, internationally as well, the same thing. A lot of blood donors become iron deficient because we remove blood. In high-income countries, whenever we see a patient with iron deficiency, especially in an adult male, for example, we think about blood loss from a gastrointestinal bleed. And of course, in women, the key driver of iron loss and blood loss is menstruation. And so in girls, as they pass menarche and there is the onset of menstruation, that becomes a challenge because they're not only losing iron, they begin losing iron through menstruation, whilst also perhaps also having diminished iron stores due to inadequate nutrition and through the growth and the consumption of iron they've required over their late childhood years.
Yeah, so a very important point that you've just made. We've also, as you've been talking, you're focusing a lot on iron, which is absolutely right. But you also made the point that, of course, there are multifactorial causes of anemia. So anemia starts in adolescence, and that gives women who are entering their reproductive life cycle a bad start. Now, whilst not wishing to diminish in any way the significance of anemia in all women, I'd like maybe to concentrate for most of the rest of this chat about the impact in pregnancy, where the impact is the greatest. Santa, can you first summarize for us the reasons that anemia in pregnancy can be so harmful?
Absolutely, Andrew. In fact, there was a recent publication in the last few days that demonstrated that the risk of postpartum hemorrhage is much higher in people who have anemia. And in fact, some of our own data has supported that finding. Anemia in pregnancy is also associated with a lower birth weight in particular, and maybe with premature birth as well. There's been other studies, of course, that show that women may have all sorts of complications to their pregnancy, symptomatic fatigue, lethargy, maybe even some impacts on their cardiac function because of the hyperdynamic circulation during pregnancy. So it's important that women have an adequate hemoglobin and are protected from anemia during pregnancy. And then, of course, after birth, when women deliver their baby, that's commonly associated with blood loss, well, almost always associated with blood loss and sometimes substantial blood loss. And that places the women at risk of postpartum anemia, where again, then as well, continuing the cycle. And so it's a really crucial period of time to focus on.
My next question is, you've told us that the cutoffs in the second trimester are lower. Can you explain what happens to hemoglobin levels in pregnancy and why that occurs?
Pregnancy is a very dynamic time. So there's a lot changing in lots of different organ functions. And of course, there's a growing baby and placenta as well. But I guess over the course of pregnancy with regards to anemia and with regards to iron stores, that it changes month by month and obviously trimester by trimester. The woman initially actually sees some protection of her iron stores because she ceases menstruating. But before too long, her plasma volume expands, seeing a reduction in her hemoglobin concentration, which is, of course, the ratio of red cells to the plasma in the blood, but she also expands the number of red cells that she makes by, I think, 30 to 40%. So a huge expansion in the amount of red cells. And that ratio is really crucial to ensuring that there's both adequate oxygen carriage, but also enabling the blood to circulate through all the small blood vessels across her placenta and elsewhere. Thereafter, we see iron consumption for needs for the fetus grow and also for the placenta, and that those needs change, particularly as the second trimester kicks in, and then into the third trimester, we see quite substantial iron requirements for the baby as the baby's growing as well. And then as we reach delivery, of course, there's iron losses associated with labor and with delivery. So across all that time, there's a really kinetic change to the amount of iron that the mum needs and her hemoglobin status. And we do see in the second trimester a relative dilution. So even though there's an absolute increase in the amount of red blood cells circulating, there's a relative dilution because of the plasma volume expansion too.
And that is an intentional physiological process to help, as you described, to maybe thin the blood a little so that it doesn't get blocked in all the tiny little spiral arteries that go into the placenta. So I was always struck that for a few years, until you recently reduced those thresholds, we were in a strange situation where the optimal hemoglobin in mid-pregnancy was actually lower than our definition of the threshold. And that optimal, at least as I understood it, was taken from some work that Phil Steer did in 220,000 pregnancies at St Mary's Hospital in London, where they showed that actually having a high hemoglobin in mid-pregnancy and failing to hemodilute was harmful. And so I think that you've nicely described why that physiological process is important and how that now fits much better with the cutoffs that you've designed. Am I right there, Santa?
Yeah, indeed. I think it's the classic U-shaped distribution of optimal hemoglobin across pregnancy. And you don't want to have anemia and you don't want to have a hemoconcentrated state either.
Yeah, okay. So, as a consequence of the very high prevalences of anemia in low and middle income countries that you've described earlier, and the harms that you've just described, and the fact that much of this can be attributed to iron deficiency, WHO recommended decades ago that women should be given iron and folic acid, IFA, in pregnancy, a recommendation now superseded by multiple micronutrients, including iron, as we cover in another podcast in this series. There have been many formal randomized trials of IFA, iron folic acid, as an intervention. In fact, you and I, we've done one together in the Gambia with our colleagues. And there's been numerous meta-analyses. Santa, could you just summarize those for us?
Yeah, absolutely. So you're right about the numerous meta-analyses. There's one that there are so many, and it's hard to keep up. I think I'll just provide a really simple headline here. So firstly, it's completely clear that giving iron supplementation during pregnancy improves hemoglobin concentration and reduces anemia, and in particular, of course, iron deficiency anemia. So many studies have shown that that's a consistent pattern. So it certainly does what it says on the tin, and iron interventions will reduce anemia and iron status and improve iron status. But the next set of questions is, does it improve those functional outcomes, particularly for the baby? Does it improve low birth weight and so forth? And there, the evidence is a little bit less secure, but there certainly seems to be, across the history of trials and the meta-analyses that have been done, evidence of a reduced risk of low birth weight in women who've been randomized on these trials to iron supplementation compared to randomized to control. Mm-hmm. And that's probably maybe a 10, 15% reduction in that risk, which is important. Maybe we see a little bit less security on some of the other questions around, for example, premature birth and some of the other outcomes, but clearly the birth weight story is crucial. One thing I found intriguing, and actually even from my own experience, is we're not very good at recording how the mum's feeling. So for those of us who ourselves have been anemic or have partners who've been anemic, we certainly know that they feel pretty rotten when they've got anemia. But even in my own experience, I'm not sure about yours, Andrew, that idea of a patient-reported outcome that captures anemia and how people feel has certainly been something that I think is missing in how we report these studies, because often we just look for those hard endpoints around birth weight, but we miss the idea that a woman might be feeling miserable and not being able to have optimal well-being over the course of a pregnancy because of anemia.
Interesting, Santa. And I totally agree with you that we should incorporate the women's view into this much better than we have in the past. And I applaud you for doing that. But Santa, before we move on to a final question about a new approach you've taken, I just want to wind back a little bit. So you said, in talking about the meta-analyses, you said very clearly, and I totally agree with you, that, it does what it says on the tin. But another side of that is that it doesn't completely do what it says on the tin. So unfortunately, even when we give iron and other micronutrients under the best of circumstances with directly observed to make sure that the women are taking it, we don't get rid of all anemia. Can you just say some words about why that is the case?
Yeah, that's definitely true, Andrew, and something that's always been on our mind. So I guess there's a few different explanations for that. One is that I think we alluded to earlier in our conversation, that not all anemia is iron deficiency. And in a lot of these studies, including a lot of my studies, we don't comprehensively profile the cause of anemia. So I think it's iron supplementation tends to really help iron deficiency and iron deficiency anemia. And we do see very profound effect sizes in the reduction of anemia or iron deficiency anemia from iron interventions. But of course, anemia might be due to infectious diseases, malaria, for example, or there might be genetic drivers of anemia, such as hemoglobinopathy, for example, carriage of thalassemia or something similar, red cell membrane disorders. The causes are, there are many different causes. So, of course, we can't expect iron to improve those outcomes. And those are probably not terribly rare and more common than we recognize. And of course, with oral iron, it's not all absorbed. Although iron is well absorbed in pregnancy, it may not be fully absorbed due to inflammation, infection, and because we know that the gut can be imperfect in a lot of settings. And finally, it does take time for hemoglobin to improve. So I've often wondered whether often you see that hemoglobin improves later. It can take months for the iron to work and improve the hemoglobin, for the bone marrow to kick in and that response to occur. So it may take a bit longer than we expect for that response to occur.
And also, Santo, something we know very well, but you haven't quite mentioned yet, which is, and this brings us on to your latest trials, or some of your recent trials, is that women just simply don't take the iron because
Yes.
they like taking it. They get some side effects, particularly gastrointestinal side effects, and that puts them off taking it. So you've been taking a different approach in some trials sponsored by the Gates Foundation. Tell us about that.
Yeah, Andrew. So in high-income countries, there have been new intravenous iron formulations that have entered the market over the last 10, 15 years. In fact, some of them are coming off patent. They've been around that long. And these drugs have revolutionized the way that we treat iron deficiency anemia in high-income settings, because instead of older formulations that were either a little bit risky and had to be given slowly and under supervision of a medical practitioner, or where you could only give relatively limited and small doses in a single go, with the modern drugs, for example, ferric carboxymaltose or iron dirysomaltose, these drugs allow us to give a total dose iron replacement, for example, 1,000 milligrams of iron in just a 15-minute infusion. And so we're able to now deliver that drug to women in high-income countries, and it's used routinely. In Australia, thousands and thousands of women receive these drugs every day, and many of them receive them in primary care, almost all in outpatient care. So my thought was these drugs could work in the global setting, in low-income settings where women need the most. And so with the support of the Gates Foundation, we were able to run a program of randomized controlled trials in Malawi and more recently in Bangladesh. Other collaborators have also run these studies in Nigeria, and there's also been studies in India. And collectively, these studies have compared standard of care oral iron to intravenous iron, and with a single dose of intravenous iron, either in the second or in the third trimester, and have evaluated the impact on women, on hematological status, on the outcome for the baby, and then actually long-term outcomes for in the postpartum as well. And to summarize all of this work, I think there's probably a few important take-home messages. The first is it does work to reduce anemia, and it tends to be better than oral iron supplementation. But in fact, that benefit is strongest, I think, when you give in probably the third trimester. So in fact, that's exactly how we use the drug in Australia. So it's something we kind of knew all along. Intravenous iron has excellent bioavailability because it goes straight into the vein rather than having to be taken orally, so it works quickly. And so the best use case looks like later in pregnancy, in the third trimester when you haven't got long till the baby's coming.
Mm.
Secondly, it's clearly superior for iron deficiency anemia and almost certainly severe for anemia. But we don't tend to see an effect on birth weight in these studies, and none of the trials have actually detected an effect on birth weight other than one of the trials in India. And I guess the other thing that we've observed in our studies is that the effect is clearly sustained on anemia. So in the first trial we did, we gave the drug in the second trimester, around 20 weeks, and a year after the baby was born, so 1 year postpartum, there was still clear advantages in terms of iron deficiency anemia for the mother. So that's a 1.5 year reduction from a drug given during pregnancy. So we're starting to piece all this information together, and I think that we're working out the role of intravenous iron in pregnancy care in low-income settings, and exactly how it fits into the antenatal care pipeline.
Listen, Santa, we're going to have to wrap it up now, but I definitely want to bring you back because you just made the point sort of apologetically that you didn't have an effect on birth weight, but birth weight might not be the metric we need to think about. Did you have an effect on the neonatal iron status, for instance? Have you measured that?
We actually did measure it in the cord, and so far in the studies, the data we've got so far, we're not seeing an effect on the cord, but it's an intriguing finding, and it may relate, just to tantalise you, Andrew, to how hepcidin is being regulated in mum and baby.
Listen, I think we definitely need to get you back, maybe for one of our milestones in pediatric nutrition, dive into this in more detail, and then get you to talk us through the postnatal issues in babies and infants. So I will bring you back for that, if I may. Santa, thank you. Huge thanks to you. You, again, for listeners, you can tell from my voice, I'm sure, that I have the hugest admiration for Santa. Not only the amount of work he does, which is prodigious, but the range of work he does. He's just got a new paper out, which is of great interest to me, on how iron affects susceptibility to malaria and the mechanisms by which that occurs. So a huge productivity, most importantly, a huge impact on global public health. Thank you, Santa, for all the work that you do.
My pleasure, Andrew. I can't wait till the next time we get to speak.
Let's do it. And it remains for me to sign off in the usual way by encouraging our listeners to share this episode if you've enjoyed it and leave comments on LinkedIn or whatever platform it is that you use to access it. Please also do subscribe through the NNI website or the NNI 365 app to ensure you don't miss future conversations, including the one I've just mentioned that we'll do with Santa about the neonatal and infant issues around anemia.
Thanks for listening to Milestones. Explore more expert insights on the Nestlé Nutrition Institute website and follow us on our social channels. See you next time for another milestone in nutrition.